To start his talk, OCTA Widefield Panorama. Dr. Daraius is the Medical Director of SHROFF Eye Center, Delhi, and he has been my co-fellow at Shankar Nethralaya, and he's a wonderful vitreoretina surgeon and a very experienced one, practicing in Delhi and Gurgaon. Dr. Daraius, please.
Thank you so much. Thank you, Secretary, for this opportunity and for the kind introduction. So I'll just speak about the Widefield Panorama of OCTA. And something which we need to remember is the innovations, the kind of rapidity of innovations in OCT imaging continues even as we speak right now. So this is a very crowded slide, but just showing that 3 decades of OCT history from the lab, it's gone into our clinics, and it just keeps getting better and better. And the reason why it has been adopted is because it's available, affordable, and extremely applicable. So I'll just concentrate a bit about the swept source OCT because that's what we are currently using. Basically, because of its faster laser and longer wavelength, it has higher sensitivity. And when we try to see the clinical benefits, we are getting larger scans, high quality scans, less noise, and also the wide field ability. The reason is that it avoids a spectrometer, so there's no signal loss, and the electronic tuning, which allows a faster A-scan rate. So to put it crudely, since we're in Mumbai, SSOCT, sab kuch dikhta hai. So let's see if that's true or not. So here you can see the Plex Elite versus the Cirrus, and you can see it's a deeper and much wider scan because of this technology. And this 9x15 is a very good size because it allows you to see most of the areas of the retina you're interested in. But other scans which are available are, of course, the 3x3 for seeing macular pathologies, the 6x6, 9x9, and the 12x12. So when advantage of the 12x12 is that if we take 5 individual 12x12 and we kind of montage these with 1 in the center and the 4 in the around them, we get a 100-degree field of view, and this is a wide field montage which we find quite useful. So let's not move into practice from theory. Let's see some situations where it is useful. So this was a case of PDR with multiple NV, again a nephropathy case. Some of these cases have multiple comorbidities, so we may want to avoid angio with a dye. Also, we don't want to repeat an angio with a dye in many of these patients. So you beautifully can see the peripheral neovascularization based on non-invasive OCT angiography. So we thought we'd study this a little in detail. So this was a case where we can see the laser being done, which caused a regression of diabetic retinopathy. So in the above slide, you can see this was the NV tissue, and you can see the flow also. So these red dots inside the tissue are the flow on the OCT angio, and you can see the amount of flow in this tissue, and you can see below that after therapy, the flow is totally gone. You just have this fibrous stump left. And this is the picture. The first two are on OCT angiography, and the last one is using fluorescein. So we just can compare the fluorescein dye with the OCT. You can see, of course, leakage cannot be seen on OCTA, that other speakers will be telling you also. But you can see the structure of the NV beautifully using the OCTA. A large amount of groups, especially Dr. Ricky Wang from University of Washington, have kind of worked on this and kind of automated it and found an automated technique using ImageJ and other softwares where the severity of diabetic retinopathy can be predicted just using an OCTA image. This was another image of ours on OCTA, and this, we are happy to say this has been used by the ASRS for the history of retina module. And this was another area we can see how on the FFA you see diffuse leakage, but you can see the detail of the neovascularization beautifully seen using the wide field OCT angiography. Similar case, again a pre and post-op. This was published in JAMA Ophthalmology, where we can avoid the dye-based angiography, and you can see the regression of the neovessels just using the OCTA. Moving on to retinal vein occlusion. Is it useful for RVO? Yes. You can see how beautifully the non-invasive image can catch. You can see the collaterals, the CNP areas in a case of a BRVO and CRVO respectively. This was a challenge, another case which we had a 65-year-old lady who, the superiotemporal BRVO, who had recurrent hemorrhages. Again, diabetic nephropathy. We see the OCTA picks up these areas beautifully. And what is important is when we do a section, we just see the VR interface slab, and you can see the raised NV beautifully on this. And further laser was added for this case. This is another patient with leukemia because of CML and absolutely featureless retina, not much macular edema, but pressures were high in the left eye and NVI was detected. And you can see the wealth of information, the amount of CNP areas seen in both the eyes using the OCTA And of course, such a case, systemic therapy is important. You have to give anti-glaucoma medication, anti-VEGF, laser, and the left eye also underwent DLC because the visual prognosis was poor. PCV is always interested me because we can be pessimistic. If we say that there's a variable flow pattern, there can be high flow and low flow. OCTA doesn't pick up either. The segmentation and projection artifacts are there because of the large PED. And there's so much edema and hemorrhage, so we may not pick up anything. So here you can see, now we compare the ICG with the OCTA, and you can see the ICG shows the polyps better, but the OCTA shows the BVN better. So here we have another case with extrafoveal polyps with a large BVN. And here you can see the polyps are the yellow arrows. Those are seen well, but much better you can see this extensive branching vascular network. PHCR is a disease in which I have particular interest. So here you can see beautifully the peripheral polyps on the fluoresceint angiography. But even if we look carefully and segment the OCTA, you can see these polyps are being picked up, and you can compare them to the structural B scan below. So this was another thing which we kind of published in IGO case reports, the WIDEFIELD OCTA picking up these peripheral polyps in PHCR. So this is all what is there, but there's a lot of things in the future. There are more options coming. There's a wide scan with an add-on lens, which goes up to 4 millimeters. And also other downside of the current swept source OCT, which we are using, is that we don't have quantitative flow measurement, but this is also in development. So there's lots to look forward in the future. So I'd just like to conclude that it has a definite role in cases with diseases involving the mid-periphery and periphery of the retina, may be critical for patients where invasive angiography is contraindicated because of systemic reasons, etc. And the advantage is being non-invasive, even if it's not contraindicated, we can repeat it frequently to monitor therapy because we don't want to do invasive tests again and again. Initially, we may like to do a fluoresceint angiography definitely as a gold standard, but to follow up these patients is good. Limitations include costs, challenge in image capturing, and artifacts, all of which will be covered by my colleagues here. Thank you so much.
Thank you so much, Dr. Daraius. It was some really wonderful pictures and great clinical applications of OCTA. So I think it's a wonderful technique and a very non-invasive one, and that helps us speedily pick up diseases and allows us to treat them without even going for the gold standard, which is the fluoresceint angiography in a lot of circumstances. So it has, I think, slowly and gradually, it is eventually going to replace fluoresceint angiography and probably maybe even ICG in the future with deeper wavelengths. Thank you so much, Ras. Any questions, please?
Very good talk, Daraius. It was nice seeing your images. Currently, the utility of the wide field, especially now, RVO, definitely it is useful because you get to know about the CNP areas, how much area is involved. In diabetic retinopathy, it is not very much useful because, again, identifying those new vessels, it's important your segmentation should be very good because if the segmentation problem, you will miss those. And more important is, while I use it more, I definitely get a SSOCTA in all my patients. You get to know these CNP areas. Yes. Because many times, even with anti-VEGF, the disease progresses. Clinically, you may not identify whether it is mild to moderate or moderate to severe. But seeing these CNP areas progression gives you idea about the disease progression. So I think understanding the disease progression is more important. There is a role of wide field.
I think, that a lot of time you have to spend if you want to actually see that.
Absolutely.
So it's nice to show like that, but it's actually very time consuming. Yeah. And even taking these images is time consuming. So we have to keep all that in mind.
The other thing which we have recently started, I think one of the talk of Dr. Sadda, after that he had told to increase the view using a 20D aspheric glass, using SSOCTA.
Oh, okay.
So rather than per 12 millimeter, it becomes 16 millimeter, especially when you're trying to look at those subtle NVs. And we also tried using contact lenses. Okay. So aspheric lens, those LVA glasses, and even you can use a +20 contact lens. Then the peripheral distortions are not much. So that's also what we have been doing now.
So Dr. MPSI described this with a normal OCT, na?
With normal OCT, he has described the same thing with SSOCT because taking montage again, as you said, it's a time consuming thing. And with a single, if you are able to get instead of 12 or 16 mm scan, And when you use a contact lens, it becomes nearly about 18 millimeter. The purpose is to look at those subtle NVs which you don't want to do in angio.
That's a good idea. Okay.
And I think in diabetics, another great role is that, they are, they are compromised already. They have kidney disease. You have to give half the dye. There are lots of issues. You want to pick up macular ischemia, that you see beautifully in this. You don't need much better than a fluorescein angiogram, because in that the leakage masks a part of the FAZ. So if you do that, it is a great help. Second, in dense asteroid hyalosis, I've picked up NVEs on this rather than, just even by clinical examination, you can't even stage the retinopathy. But if you have this machine, that's a great boon, rather than making them go through angiogram every time they come. Yes, please.
Yes, sir. Aaron, sir, have you noticed any fixation issues while using the 20D lenses?
Which issues?
Is the patient able to fixate quite nicely?
No,
through the
they
20D
fixate
lenses?
because see, when you are planning it, if the macular ischemia and other thing, definitely if fixation is bad, the overall image quality is bad. But this is only when they are able to fixate a little bit, you can take. Yes, but the periphery with a 20D, whatever you get that extra is not very clear.
Correct.
It's not as clear as the central part.
Any more questions?
Can it replace ICGA if it is not available in IPCV?
Dr. Reyes, I think.
Darius, you want to
Reyes
take
has, done a lot of
So,
work.
sir, actually the problem is the polyps are not very well seen with the OCTA, but the branching vascular network, it are seen well. So I would recommend that maybe first time, please, we should do ICGA, but for following up these patients, it's very useful so that we don't have to keep doing invasive angiography or ICG angiography.